there's a disclaimer. I'm not an expert in rTMS. We just got the rTMS machine. It's the same machine which you have in AIIMS, and we just got it 3 months back. So once this machine came to our medical college, I was talking to various psychiatrists in Prayagraj and amongst our colleagues, and they were asking me, okay, now that rTMS is there, so what can we do with rTMS? How can other psychiatrists, the clinical practitioners can gain from this field in the medical college? So I would be speaking more from a clinical perspective, from questions which arise from our colleagues, from psychiatrists who are in private practice also. And I would take this opportunity to learn from Dr. Sujit and Professor Mona, who have more experience in rTMS besides Dr. Shruti. So with that, I'll start. So what are the reasons of increasing use of rTMS? We all have been having so many medicines in psychiatry. We are having so many techniques, counseling, but there is still a treatment gap. And rTMS is a very good non-invasive application that has come, and it has shown that it is more acceptable to the patients as compared to ECTs, which use has becoming decreasing nowadays because of the increased legal implications and the stigma which has been there from some times immemorial, and we haven't been able to deal with that. What are the benefits which we get from rTMS in our clinical practice? First of all, it addresses treatment resistance, offers hope for patients who are not responding to medications and psychotherapy. Very well-known example, and it's been mostly used in depression and OCD. It is non-invasive, well-tolerated. It has precision targeting, which Dr. Shruti just mentioned. We have MRI, we have functional MRI, in which we can actually target. Suppose a patient has had stroke, we can actually see the MRI and fMRI, and we can use and place our coils and plan our protocols accordingly to that. Dr. Shruti had already mentioned that it enhances neuroplasticity, especially in stroke, depression, chronic pain, and otherwise also. It has expanding application, just not in psychiatry, but most of the machines are now commonly there in the Department of Psychiatry and Neurology, and also rehabilitation. In fact, even in Prayagraj, our machine is jointly being used by both the Department of Neurology and Psychiatry. Again, it has minimum systemic effects, as we already mentioned, because we have precision targeting and it is a non-invasive method. So what are the indications? Have been already briefly mentioned. We had the first indication or the US FDA approval, which we got, was in 2008 for major depressive disorder. Then later on in migraine, for migraine 2013-14. Then obsessive compulsive disorder, it was approved in 2017-18. 2020, smoking cessations. Also emerging experimental indications for PTSD, also GAD, major depressive disorder with anxious overlay. Addiction has been shown to have good results, especially in smoking, also in other addictions like cocaine. Chronic pain syndrome is something which the neurology colleagues are also very, very excited about. And since we have mentioned about neuroplasticity and motor stimulation, so we also have a role of rTMS in stroke rehabilitation, besides auditory hallucinations and all in schizophrenia. The timeline, we've already spoken about this, of the FDA approval which we got for rTMS in various disorders and in certain disorders which has been used. There are certain screening questionnaires for rTMS which we have been broadly described. There are some contraindications for rTMS, and these are the patients which might not be able to take. Maybe absolute contraindication can be cochlear implant, because the problem happens is if you use an rTMS, that causes heating. This can lead to the implants or the metallic implants which are there in our brain to get heated up. It can cause certain side effects, but absolute contraindications are not there. There are indications where it can be safely used in pregnancy, also in child psychiatry. However, FDA approval is yet to come. In TMS, if it has been used in the past, or if an MRI has been done, it actually decreases our ease of use, or it helps us, because there are certain protocols which are common in MRI screening are also there in rTMS, which Professor Sujit is going to talk more in detail now. So as I said, I'll discuss more of the cases which we get and which we think rTMS would be a good treatment option. For example, this is one of the females patients we had in Prayagraj. She had major depressive disorders, many episodes. She's been having it for 9 years. We have been given a trial of escitalopram, and according to the STAR-D protocol and CADMAT guidelines, after adequate trial of SSRIs, we augmented the patients with mirtazapine. Not getting any response, we tried SNRIs. Desvenlafaxine was used. Again, no response. We started augmentation with aripiprazole. With aripiprazole, she developed a lot of akathisia, and she did not want to take it. Problems happened with sleep disturbances, poor appetite. She, at that time, also developed certain suicidal ideations. So we went for lithium augmentation, although there was no history of any bipolarity in the patients. But again, even with lithium, she did not show much response. She by the time also came to know about the online CBT which is available, and she contacted a psychotherapist, and she had sessions of CBT. Again, no improvement. She continuously used to talk about brain fogging and not able to work, loss of memory, and persistently having low mood, early morning awakening, psychomotor retardation, feeling a lot of fatigue, and suicidal ideations. Her Hamilton Depression Rating Scale was 24, and because she was from a middle-class family, she used to work partly as a teacher, and she could not continue her job, and she became dependent more on her family and in-laws, which was also one of the problems she presented with. So Dr. Sujit, like he just spoke about that rTMS is beneficial for usually first patients, but again, in this patients, we have rTMS, which can be a good treatment augmentation or another armamentarium in our course for managing these kind of patients. Suicidality also, rTMS has been shown to reduce suicidal ideations. For that, accelerated rTMS sometimes for acute suicidality. Not my experience so far, but this in future can also be one of our accelerated rTMS, which maybe Dr. Sujit Kar and Dr. Mona would elucidate further, could be one of the also beneficial effects of using accelerated rTMS, and certain times it has been seen. Another case we had, a 31-year-old female, she was suffering from severe OCD. Her duration of illness was 6 years. She had repeated checking rituals, obsessive doubts about blasphemy, and magical ideations. She also had comorbid generalized anxiety. What used to happen was, this was like something which was the patient, when she was referred to us, she had also visited the orthopedics department. Her magical belief was that she used to always keep her fist closed. And she started developing contractures because of that, because she used to think if she would open her fist, it would lead to something bad happening, or somebody might actually have a head injury, or her head might burst open. She also had, the place she was staying was, there was in her room and in between her kitchen, there used to be a lobby where there was a small mandir. And every time she used to go from her house, from her room to the kitchen, she used to cross that, and she used to close her eyes and not look towards that mandir. And because of that, she several times had a fall. She used to fall down. So all these problems she was having. We had given her an adequate trial of fluoxetine. We reached our target dose of 80 to 100 milligram. No response, although it caused a lot of side effects like severe GI upset, insomnia. Same thing happened with sertraline, intolerable nausea and GI side effects. Clomipramine was added. It was built up to 75 milligram, but even with that, she had a lot of sedation. And because she used to keep her fist closed. A little bit of work she used to do, she started developing tremors. And because of that, she refused to take all pharmacotherapy voluntarily. Once she came to us, her Vibox score was 28, which was in severe. And because of the daily distress and impairment in her work and social life and failed ERP trial, we decided to give her rTMS. The third case, as I said, the rTMS, like any other treatment protocol, it has been found more helpful in treatment naive patients, or if we put rTMS early in the treatment disorder. Now we have pretty well-read people. So this was a patient, software engineer. He had an obsessive doubts with compulsive checking. He had a pretty good insight into his history. He just had a girlfriend, and he had actually read about SSRIs and the sexual side effects which SSRIs cause. And he came and said that I'm not interested in taking SSRIs because they're going to cause a lot of sexual side effects. And I've read about rTMS, and I'm willing and I'm giving my consent. And please, doctor, now that I've read that it is there, so I would request rTMS, and my family and my girlfriend and all are more interested in this form of therapy. So this is like with more and more better read people, more aware people, we have more acceptance of rTMS. This is another case which was there in our neurology department. Around 60-year-old male. He had an ischemic stroke in the left MCA territory 10 months back. Because of that, he had hemiparesis, and with the hemiparesis, which was he was given treatment and exercise, and he started improving, gradual improvement of power, but full recovery did not happen. And the past 3 or 4 months, his improvement started decreasing. That plateau phase also led to onset of depression. His depressive symptoms were apathy, low mood, fatigue, withdrawal, and again, we included the motor deficits. And because of the protocol, he was hypertensive, diabetic, and prevention. So he already was on 12 or 13 medications from other specialities. And once we had started him on, again, escitalopram was started, but he had poor response to it. The patient, again, because of the amount of medications, he started becoming fatigued, demoralized, and often used to stop taking his medication. So along with our neurology colleagues, we have planned to give rTMS to this patient. So I'll conclude by saying that obviously we still have a lot of consensus recommendations highlighting the issues in rTMS and also the possible useful uses which we have. As more and more centers start using rTMS, we would have more data from India. And as more and more practitioners start using it, we would have real life indications and real life problems, and implementation of rTMS based on evidence-based recommendations, and also more and more data regarding its safety and efficacy. Obviously, it's something which we just started using, and we need additional research and to determine the optimal treatment parameters and algorithms for implementation of rTMS according not just in academic institutions, but also in general day-to-day life. Yeah. Thank you.